So now we're going to talk about atlas fractures and transverse ligament injuries. So atlas fractures make up about 7% of all cervical spine fractures. The risk of neurologic injury is actually relatively low, and this is for the same reason as for odontoid fractures. It's because at this area, the spinal canal is actually relatively large compared to the cross-sectional area of the spinal cord, so you have some extra room there. However, these injury patterns are commonly missed. Again, x-rays and imaging at the base of the skull can be more difficult just because of the large amounts of osseous anatomy, so these fractures are often missed. So in terms of the pathophysiology, the mechanism can be really any type of vector force. You can have a hyperextension injury, a hyperflexion injury, or axial compression, which is the mechanism for the most common fracture, the Jefferson fracture, or at least the best known fracture of the atlas. In terms of associated injuries, there is a high rate of spine fractures associated with this injury. 50% have an associated spine injury, and about 40% have an associated fracture of the axis or C2. In terms of the prognosis, the most important variable in terms of the prognosis is the transverse ligament and its healing potential, and we'll talk about that in a minute. So just going over the anatomy of the atlas. So the atlas is really a ring-shaped structure. It consists of two articular lateral masses. It is unique in that it lacks a vertebral body and it lacks a spinous process. It does, however, have a transverse process, and the vertebral artery goes through it. In terms of the embryology, it forms from 3 different ossification centers. You can see that here in this illustration. That is different than the axis or C2, which is formed from 5 different ossification centers. You should be aware that there is often some anatomic variation. The most common of these is an incomplete posterior arch. This is important when you're doing your posterior cervical surgery to be aware that that posterior arch of C1, which is your landmark that you often dissect down to, it might be incomplete, so you have to be careful. You can see here this is an x-ray of an incomplete arch, and you can see that there's some sclerosis around this bone here, so that does not look like an acute fracture. As we've discussed with odontoid fractures, the occipital cervical junction and atlantoaxial junction, they're both very interesting junctions, and they're actually relatively complex in terms of the amount of motion that they're responsible for, and also by the fact that the spinal cord goes through them. And for this reason, you have a somewhat complex ligamentous structure that consists of a series of ligaments that span from the C2 area all the way past C1 and to the base of the occiput. The first of these ligaments is the transverse ligament, and you can see that here. The transverse ligament is the primary stabilizer of the atlantoaxial joint, which is seen here. So looking at this illustration, this is the posterior arch of C2, where this is the ring of C1, and you can see the dens of C2 comes up inside the arch of C1, and so this makes up that atlantoaxial joint. The dens of C2 is really hold anterior against the anterior arch of C1 by a series of ligaments. The most important of these is this transverse ligament that originates from the lateral mass of C1, wraps around the odontoid, and pulls it anteriorly. That's better seen in this somewhat superior view. Again, this is your occipital cervical junction facet of C1, the atlas. So this is your ring of your atlas, and you can see this is transverse ligament pulling the dens of C2, which is inferior to it, anterior against the anterior arch of C1. There's another ligamentous structure that's important to recognize here, and that's the alar ligaments. Now, the alar ligaments in that prior illustration we were just looking at go from the dens of C2 straight up to the occiput. So they're involved in the stability of the occipital cervical junction. Again, there's two junctions you need to think of here: the occipital cervical junction and the atlantoaxial junction. The transverse ligament is important in the, or more important in the atlantoaxial junction, whereas these ligaments go from the dens up to the occiput, so they're involved in stability of the occipital cervical junction. So this is another view of those paired alar ligaments that go from the dens of C2 going up to the lateral condyles of the occiput. This is a posterior view, so you can see the posterior arch of C1 has been removed. The posterior arch of C2 has been removed, so you're looking posteriorly at the spinal cord. You know this because you can see these are your anterior horns of the spinal cord. So here you're looking at the transverse ligament pulling the odontoid anteriorly, and then sitting just more anterior to that is these paired alar ligaments seen here in blue, going up and stabilizing the odontoid to the base of the occiput. There's one other ligament that sits alongside the paired alar ligaments. This is the apical ligament, and here you can see that in green. It's a small single midline structure. It goes from the tip of the dens, remember apical apex, straight up to the occiput. I like to remember alar, L as in lateral. The alar ligaments go lateral, so again this is A as in apex apical ligament. This is what that apical ligament looks like from the front. Now we're looking from the front, so again this is your body of C2. This is your anterior arch of C1, and if we remove some of that anterior arch of C1, the first thing we're going to see is the dens. This is the apical ligament going from the dens up to the occiput. Those are the alar ligaments. Again, from this view, the transverse ligament, which goes posterior around the dens, would be behind these layers, and the spinal cord behind that. There is one other ligament that I've never seen it tested. It's not an important stabilizer in this region. It is the tectorial membrane. The reason it's interesting and useful from an educational perspective is it is really an extension of the posterior longitudinal ligament. So down here, if you're operating, in the cervical spine, say you're doing an ACDF, you're going to come in anteriorly. The first thing you're going to do is take down the anterior longitudinal ligament. Then you're going to do your discectomy, and if you're doing an adequate decompression of the spinal cord, then you have to get through your posterior longitudinal ligament. This ligament here, the proximal extension of that, wraps around posteriorly to the transverse ligament, which again hugs the dens to the anterior arch of C1, and then it becomes the tectorial membrane that goes back up and migrates just basically parallel to the apical ligament to attach to the occiput. Again, this is really interesting because it's an extension of the posterior longitudinal ligament, but it does not provide a significant amount of stability in this region. So looking at the classification of atlas fractures, atlas fractures, you can break them down into both bony atlas fractures, and then you want to think of the transverse ligament injuries. Atlas fractures can be broken into three types: type 1, type 2, and type 3. Type 2 is the most common one we hear about, which is the Jefferson fracture. So a type 1 fracture is really an isolated injury to either the anterior or posterior arch. Usually these are mild non-displaced fractures. There is a type of fracture called a plow fracture, which is basically a more significant type of type 1 fracture where the dens is actually driven through the anterior arch of C1. So this is just kind of a schematic looking at all the different types of atlas fractures. Atlas fractures can really come in all shapes and sizes and can involve either the anterior arch, the lateral masses, the transverse processes, or a combination of all of the above. As we mentioned, they can also be transverse ligament injuries here. So the type 1 that we just discussed is an isolated either anterior arch fracture or an isolated posterior arch fracture. This x-ray actually shows what that plow fracture would look like. You can see this is the anterior arch of C1. Something has blown through it anteriorly. You can't really see the dents here, but on a more inferior view you can see that the dents has been driven forward and essentially breaking through or plowing through that anterior arch of C1. So type 2 fractures are the ones we hear the most of. These are your Jefferson burst fractures. The mechanism of these injuries is in axial loading, and it leads to a bilateral fracture of the anterior arch and the posterior arch as you have these radial forces pushing everything outwards due to the axial loading. This is an example of that. Here you can see a bilateral fracture of the anterior arch, a bilateral fracture of the posterior arch, and again this is due to axial loading. This is what it looks like on the illustration. The lines marked in red indicate a Jefferson fracture. Again, bilateral anterior arch, bilateral posterior arch fractures. Last one is type 3. This is a unilateral lateral mass fracture. So if it's unilateral, it would be here. Usually there's two fracture lines, both anterior and posterior. This is what that fracture would look like on a CT scan. Again, here's your lateral mass. Here you see a fracture of the anterior arch, and usually you see a fracture of the posterior arch as well, but it is a unilateral fracture. You know, the most important thing in determining whether these injuries are stable or not is whether the transverse ligament injury is whether there's a transverse ligament injury. So if you look here, the transverse ligament connects the lateral masses of the atlas and hugs the dens of C2 or the axis anterior. So you can see it goes from lateral mass to lateral mass. Now if you fracture this, or for instance you have your Jefferson fracture, in order for you to have significant displacement laterally of the two lateral masses, you had to disrupt this band phenomenon of the transverse ligament. So you need basically a transverse ligament injury. Now, whether the transverse ligament is intact determines the stability. You can imagine if this ligament is intact and attaching these two lateral masses, it's going to be hard for these to displace laterally, and it's going to be a relatively stable fracture pattern. So transverse ligament injuries are broken down into two types. Type 1 is an intersubstant tear, marked by here in green, and type 2 is an avulsion fracture. Avulsion fractures have somewhat of a better prognosis just because you have better healing at the bony interface than a mid-substance tear. So talking about imaging studies, most important views that you want to obtain are your AP, lateral, and your open mouth odontoid. One thing that you're looking at is your atlantal dens interval, and you're going to be looking at this on your lateral view. So your atlantal dens interval again is your distance between the anterior arch of C1 marked here and your odontoid. So normally, as we said, the transverse ligament hugs the odontoid anteriorly against this arch, and you can see here where you have significant migration of the dens away from the anterior arch of C1, and thus you have an increase in the ADI, which is this space, atlantal dens interval, and a decrease in the SAC, or space available for the cord. Anytime you have an increase in the atlantal dens interval due to the posterior migration of the dens, you're going to have a corresponding decrease in the space available for the cord posteriorly. So it's important to realize that how much space you have here in terms of your ADA represents how unstable the injury is. If it's less than 3 millimeters, that's normal. If it's 3 to 5 millimeters, that means you probably have an injury to the transverse ligament, which is going from here to here, but your alar ligaments, which go from here up to the occiput, and your apical ligaments that goes from your dens up to your occiput as well, are probably intact. If you have more than 5 millimeters migration, then that means all those ligaments are disrupted. Your transverse ligament is disrupted, your apical ligament and alar ligament are all disrupted. All of those have vector forces that pull the dens anteriorly, and if you disrupt all of them, then you have the ability for the dens to migrate significantly posteriorly, greater than 5 millimeters, representing significant instability. The other x-ray that you always want to obtain is your open mouth odontoid. They love to test the sum of the lateral mass displacement. So you can imagine that this is your lateral mass of C1, here and here. This is your dens of C2. As we just said, the ligaments around this are, you have your transverse ligament attaching or connecting these two lateral masses, and then you have your apical ligament that would go straight up anteriorly, and your alar ligaments. Now, in that axial illustration I showed you, if the transverse ligament is intact, it's difficult for these two lateral masses to displace laterally. Where if you disrupt the transverse ligament, you can have widening of these, and what you see is the lateral mass hangs over the edge of C2, the facet of C2. So you can see here, what you have here is an increase in the overhang. So this is the sum of the lateral mass displacement, which you measure from this distance from here to here, and this distance from here to here. Now, it used to be thought that if the sum of the lateral mass displacement was greater than 7 millimeters, that was unstable. More studies have shown you have to take into consideration the radiographic magnification. So now it's really accepted that if you have a sum of the lateral mass displacement of greater than 8.1, that means that your transverse ligament your transverse ligament, it's disrupted and it's an unstable fracture pattern. So again, this is frequently tested. Sum of the lateral mass displacement of greater than 8.1. Again, that means the transverse ligament has been disrupted, and that means it's unstable. If you have a greater than 5 millimeters of your atlantodens interval, again, that means it's unstable, and that's due to an injury of the transverse, alar, and apical ligaments. This is a typo right here. This should be alar and apical, and we will correct that. Due to the difficulty of interpreting these radiographs at the base of the skull, you really want to get a CT scan on a frequent basis. I would see when I take call in the hospital, elderly people that fall, x-rays are normal. You get a CT scan, you often see, a very mild non-displaced fracture of either anterior arch or the lateral mass. So you really want to obtain a CT scan. We also mentioned there's a high degree of associated spinal injuries in both in the cervical spine. So you want to obtain a CT scan of the entire cervical spine. MRIs can be useful if you're suspicious for injury to the transverse ligament. If you have, you can have transverse ligament injuries without any bony fractures. So if you do see, migration, the atlantodens interval, there's no evidence of fracture on your CT scan, then you want to maybe perhaps obtain a MRI, and you might see this hyperintensity here, which represents an injury to the transverse ligament. This is probably an avulsion injury here. All right, so now we're going to talk about treatment. It's very unlikely that they're going to ask about treatment of atlas fractures, and the reason for this is treatment is actually quite controversial. There are 3 different treatment options. One is a hard cervical orthosis, the other is putting a patient in a halo, and the last is surgery, either with a posterior C1-2 fusion or occipital cervical fusion. There are a large amount of these atlas fractures that can be treated in a cervical orthosis. These are your non-displaced type 1 fractures that you see actually quite a bit of. They can either be a non-displaced anterior arch, non-displaced posterior arch, a non-displaced lateral mass fracture, or isolated transverse process fracture as well. Indications for halo immobilization. This is again quite controversial. It's kind of accepted that a stable type 2 Jefferson fracture, so you get a axial CT, you see fractures the anterior and bilateral fractures the anterior and posterior arch. However, there is not significant displacement, so it qualifies as a stable type 2 Jefferson fracture. A lot of people would say you would treat this with halo immobilization. That is also true for a stable type 3 fracture, where there's no significant evidence of stability, but you have a unilateral lateral mass fracture. In terms of when these patients require surgery, it's really when you see a significantly unstable fracture pattern. Again, this would be represented by an atlantal dense interval of greater than 5 millimeters on your lateral, or some of the lateral mass displacement of greater than 8.1 millimeters on your open mouth odontoid. Again, both of these represent significantly unstable fracture patterns. It can either be a type 1 or a type 3, and these are patients that most people would say you'd treat with some type of surgical stabilization. Now, what techniques to use? It's either going to be a posterior C1-2 fusion or a occipital cervical fusion. Whether you can do a C1, C2 fusion is really dependent on what the fracture pattern looks like and what is the integrity of your lateral masses. So in a lot of fracture patterns, you are able to obtain significant purchase with your lateral mass screws. If you can do that, that's great. Then you can put in pedicle screws of C2 and create a C1 lateral mass C2 construct. This is a much better operation if you can get away with it than a occipital cervical junction. A occipital cervical junction will provide enough stability, but really to get a good purchase from the occiput, you're going to have to go down to at least C3, and you can imagine that that leads to a significant amount loss of motion. Just quickly going back, reviewing our cervical kinematics, you can see that your occipital cervical junction is responsible about 50% of flexion extension. Your atlantoaxial joint is responsible for about 10% of flexion extension and 50% of rotation. So you can imagine if you do a occipital cervical fusion and say you go down to C3, then you're going to lose about 60% or half of 60 degrees, or about half of all your flexion extension and about half of all your rotation, and that's non-ideal, especially in a young patient. In terms of complications seen in these fracture patterns, there are complications associated with keeping people in a C-collar for too long, so you want to make sure you clear these C-spines expeditiously. There are also high rates of complications associated with halo immobilization. Again, it's very important to remember you never put elderly patients in halos. That's associated with a high mortality rate in elderly patients. So just going through some questions quickly. Figure A shows the coronal and axial CT images of a 27-year-old that suffered a fall from a significant height. Which of the following radiograph measurements would best indicate disruption of the transverse ligament? So here's your fracture pattern. So again, if we zoom in on this, really we're looking at our axial CT. Here you see disruption, a bilateral disruption of the anterior arch, bilateral disruption of your posterior arch. So this is your classic Jefferson fracture due to an axial loading. This would be a type 2 Jefferson fracture. If we look at our coronal images, again, this is kind of similar to looking to an open mouth odontoid. We talked about the sum of the lateral mass displacement that you can either see on an open mouth odontoid or you can see it here on your coronal CT scan. This is your C2 dens. This is your C1, C2 facet. So you can see here, this is your lateral mass of C1. Now, with the Jefferson fracture, you have axial loading, so you're pushing down here, and radial forces drive this lateral mass laterally. So you have an overhang over here. So this is your lateral mass displacement, and what you do is you add that. So your sum of your lateral mass displacement on your CT scan, it would actually be 7.9 because you don't have radiographic magnification here, but on your radiographs you're looking for a lateral mass displacement of 8.1. So the question here, which of the following radiographic measurements would best indicate disruption of the transverse ligament? So an atlantal dens interval of 3 millimeters, again we went over this, an atlantal dens interval of greater than 5 millimeters really shows that you have disruption of the transverse apical and alar ligament. An ADI of 3 to 5 shows you usually have an isolated injury to the transverse ligament. So 3 is on the low end of that, so that would not be your best answer. Posterior atlantodens interval of 16 millimeters. This is the same as your SAC. An SAC of less than 13 millimeters indicates that your dens is migrated posteriorly. So a space available for the cord of 16 millimeters would mean that your dens has not migrated posteriorly significantly, and therefore your transverse ligament is probably intact. C2 pars horizontal displacement of 3 millimeters. This would not be relevant to this type of fracture. This is a displacement that you see on spondylolisthesis or hangman's fracture, and that would not involve the transverse ligament. Last one, combined lateral mass displacement of 8.2. We just discussed that. That would indicate a transverse ligament injury. Powers ratio is used to identify occipital cervical dislocations and not relevant to this injury pattern. So the correct answer here, indicating transverse ligament injury, would be C2, combined lateral mass displacement, and that's your correct answer. Next question, a Gallet C1-2 fusion with sublaminar wiring of C1 to the spinous process of C2 is a valid treatment option for which of the following injury patterns? Occipital cervical dislocation, that would not address that injury fracture. Comminuted C1 burst fracture. Just had to check that, excuse me. So yeah, comminuted C1 burst fracture. When you use the Gallet wiring technique, you're basically relying on the posterior arch of C1 to be a rigid construct and wrap that around to the C2 body in some way. So if you comminuted burst fracture, that ring of C1 is going to be unstable and it's not going to be a valid treatment option. Type 1 and type 2 odontoid fractures, a Gallet C1-2 fusion is an effective way to stabilize the atlantoaxial joint. So it is an indication for some odontoid fractures. However, type 1 fractures are avulsion injuries, and they are stable injury fractures. They're treated in a cervical orthosis. Type 3 odontoid fracture is in the cancellous bone, so those are not surgical candidates. So even though a Gallet C1-2 fusion sublaminar wiring technique could be used in a type 2 odontoid fracture that requires surgery, type 1 fractures and type 3 fractures do not require surgery. Valid treatment option, transverse ligament disruption. Again, if you have injury to the transverse ligament, that means that you have instability of the atlantoaxial joint, and a Gallet wiring technique would be a valid treatment option in that situation. Biomechanical studies have shown that atlantodens interval of greater than 7 millimeters is associated with, again, we just discussed that. If your atlantodens interval is less than 3 millimeters, that's normal. 3 to 5 means isolated injury to the transverse ligament. If it's greater than 5 millimeters, that's significant migration of the dens away from the anterior arch of C1, and that means those 3 stabilizing structures that are all pulling the dens anterior to the arch of C1, which include the transverse ligament, the alar ligament, and the apical ligament, all of those would be disrupted. So again, here this is saying it actually includes a rupture of the tectorial membrane. That would actually be true as well. There's actually, an error in this question, and we'll try to use this as a teaching point. So this is saying atlantodens interval of greater than 7 millimeters is associated with which of the following? There's a ruptured transverse, alar, and apical ligament. That is true. A ruptured transverse, alar, and ruptured tectorial membrane. So that would actually be true as well. And the reason for this is, if we go back to our anatomy section, looking at this illustration here, You can see that, as we mentioned, your tectorial membrane is an extension of your posterior longitudinal ligament. It is not an important stabilizer in this region. However, it does run parallel to your transverse ligament and also parallel to your apical ligament. And you can imagine that if you have significant migration of your dens posteriorly, meaning that you have rupture of your transverse ligament, rupture of your apical ligament, and rupture of your alar ligaments, chances are that your tectorial membrane would also be ruptured in this situation, just because it basically runs parallel to your apical ligament. It's a very weak structure, so it would be injured as well in that question. So we will actually revise that question. Hopefully going over it acted as a valuable learning lesson. So that's it for atlas fractures and transverse ligament injuries, and hope that was helpful.